So guys, this was the point which was shared yesterday, and there was some confusion like how to go about this type of question. So believe me, there are few points which will be repeatedly asked to you till you pass your exam, and AFRS is one of them. Okay. So I have just told you beforehand, this is one of the very important topics being asked in all sorts of sets. Okay. So please go in depth about it. Okay. But in this question, I'll just take a minute before we start with the regular session and go about how to go about this type of question, even if you don't know what is this HP image given about. ठीक है कि even you don't know what is this image given कि ये gross का pic क्या है, what is this stain which they are asking, still if you are able to answer how to go about it. Now let me read the history. A 30-year-old man, I'll need your help with it. Okay, so please keep unmuting and keep answering. Nobody knows each other. Okay, unmute करके answer तो maximum गलत होगा, इससे ज़्यादा कुछ नहीं होगा. A 30-year-old man presented with complaints of unilateral nasal obstruction, sneezing and coryza. On examination, there was a mass seen in the nasal cavity, which was sent for biopsy, and serum galactomannan test was negative. और इस तरीके का कुछ biopsy दिया हुआ है. तो what all can come in my mind? अगर मैं सोच रहा हूँ कि कुछ this will be something related to rhinology thing, what all can come in my mind? Let me write it down here only. It can be AFRS. What else can it be? AFRS के अलावा aspergillosis हो सकता है. Anything else which you think? Any tumor, inverted papilloma, ऐसा कुछ हो सकता है? Anything else which comes into your mind? कि ऐसा कुछ ये आंसर हो सकता है? Like if I would have been answering this question as a first year, so what all things can come in mind? इसके अलावा और क्या option? इन तीनों के अलावा any other DD you could think of? Okay, chalo. Let me go with the discussion only. What is the meaning of this thing? Serum galactomannan test was negative. Why have they given this thing? Can somebody take a try? इसका मतलब क्या है? Galactomannan negative का मतलब क्या हुआ? अरे दादा, galactomannan negative means कि
fungus is negative.
Yup, it is aspergillus negative. Okay, because galactomannan is specifically seen in the aspergillus. Okay, तो इसका आंसर when they have written कि galactomannan test negative है, तो one thing should be there in your mind कि भाई whatever can be the answer, aspergillus नहीं लगाऊंगा मैं first answer. Okay, so and when we read ahead after the diagnosis कि what are the organisms causing it, what is the positive stains which is there, name some characteristic radiological findings of the disease, name a diagnostic criteria. So if you think retrospectively, एक बार after reading all the four options and then again you think, so then this AFRS will fit in everything because we know that there is a diagnostic criteria by the name of Bent and Kuhn. Okay, there is a diagnostic criteria by the name of Bent and Kuhn. Okay, so one, what are the radiological findings we have? We all know that what is the double density sign, what sign is seen due to deposition of these elements into this. Okay, we know the stains which are specifically there for the for your AFRS, that is your GMS and all. ठीक है. हाँ. Second thing is never write any short form. It should be avoided at all cost. Okay. And suppose if apart from AFRS you are trying to write any of this answer कि मैं aspergillus लिखूंगा, tumor लिखूंगा, mucormycosis है, cryptococcus, ऐसा कुछ fit कर रहा हूँ, तो वहाँ पे you won't be able to answer from this point of view कि what can be the ये. Okay. So even if you don't get all the details just by seeing the image, please don't get bogged down. Go through the answers. What are the options they are asking, and something or the other will strike you. Of all the, it's a common topic. It will strike you कि हाँ इसमें ऐसा कुछ मेरे को पता है. Second thing, what is there is no negative marks over here. So even if you don't know anything, please don't leave it empty. It should not be कि आप उसको खाली छोड़ करके आ गए. कुछ भी आपको जो whatever you are remembering, please write it. It should not be that आप OSCE को you should not leave it blank. And attempt all the 5 questions. Just a minute, please. डॉक्टर शिवा, यू आर इन ना? हाँ डॉक्टर सौम्या, बताइए. डॉक्टर सौम्या, you want to ask, say something? Okay. ठीक है. So the article I had already shared with you guys yesterday. The image, exactly, they have taken this image from a pathology article. Okay, it's a pathology outline resources article करके है. So yesterday's that link which I had shared, please go through that. It will give you all this image, and apart from other questions which can be asked. ठीक है, all are in. Okay, so please go through that link which I had shared with you guys yesterday. That pathology में उस article में this is the exact image which they have taken. Most of the times it will be there कि image will be exactly from your Scott Brown itself, but in few cases it will be that from some of the famous articles they'll pick it up. So please go through that article, and apart from that, whatever you have studied from AFRS, it is very important. Very important. You cannot miss it. Okay, so whatever notes you have studied, oblique Scott Brown, please go through it. Okay, revise it multiple number of times before your exam, because you will find it everywhere. Whether the CT scan of this image is very likely to be asked. That they'll give you the scan and they'll ask you. I'll share the image also. That what is the finding that you are able to see? What is the probable diagnosis over here? Okay. So coming ahead. And what are the organism causing this disease? ठीक है, this is ABC. ठीक है, so what are the organisms causing this AFRS? This is ABC. A is for alternaria, B is for bipolaris, and C is curvilineria. Okay, you can answer in your own future whatever you have remembered, but this should be your favorite, like one of the favorite topic, I'll say. It's topic from rhinology, but I had to include it because yesterday's discussion there were very, I'll say, vague points which should not be there before the exam. Okay, so let's move ahead. Okay, now coming to this image, I'll read the question, and again I'll need your help to answer this question. A 45-year-old male patient presented to the OPD with complaints of impaired hearing in the right ear, listening to his own footfall. And someone wants to join. Hi, Dr. Anaga, you want to say something?
Hi, sir. Good evening, sir.
Yeah, good evening. Bataiye.
Can you just, one of the TD is fungal ball, right?
Yeah.
So can you tell something about AFRS versus fungal ball?
See, here I am just focusing more commonly about, I know the answer because when I saw this question, I'll tell you, when I saw this question, it was like in my mind, it should be AFRS. I searched on net, so I came across the article, I saw the images, and it was confirmed that ये AFRS हो गया. ठीक है? Now when you are asking whether it could be a fungal ball, definitely it can be a fungal ball, but what I am saying is when they are asking these below questions, do you know any characteristic radiological finding for fungal ball, or any diagnostic criteria for fungal ball, or any specific positive stain for fungal ball? I think there is no specific thing given about it, right? So that's why this type of thing will be there. Or agar aapko, like supposedly if they want to ask fungal ball in particular, so they will give you a scan or something, endoscopy picture like that, where you will be seeing that mycetoma over there, like that whole ball will be appreciated in that scan. So here they have just given a HPE picture to us, and what history they are giving to us? Nasal obstruction, apart from that sneezing and coryza, simple vague sa history diya hua hai, and galactomannan test is negative. So basically they are trying to drift us away and bringing to a specific type of conclusion. Okay, I'll share a CT scan of fungal ball, so you'll get better, because fungal ball ka HPE, I'll say that is very vague, that is very non-specific of fungal ball, right?
Okay. If this like they ask in Viva how the treatment varies between AFRS and fungal, both needs surgical, right?
Yeah.
Any difference between treatment, diagnosis and treatment of AFRS and fungal ball?
Yeah, definitely. The treatment is like that. I will say you should answer according to Scott itself. Okay, like what are the latest treatment protocols which are being followed? That you should answer one, and second will be this will be just a minute. Oh, where is this? I'm sorry, my this ink pen is leaking. Just a minute. Don't worry, that treatment protocol of treatment guide outlines of both the AFRS and the fungal ball. I'll share it with you guys. Okay, so you can go through it. Let's go ahead with this because it will increase the boredom of the remaining 30-35 people. Okay.
Okay. Thank you.
Okay. Now coming to this thing. Okay. So please, this thing which I have underlined over here, that listening is own footfall. This thing is characteristic of your superior semicircular canal dehiscence syndrome, right? Now, what else they have given to us? This is the HRCT image of the patient which is being shown to us. And now what they are asking is, what is the gold standard investigation for identification of this disease? Then they are asking, what is the type of hearing loss and multiple questions. So can I have the answer, please? What you will write over here? What is the gold standard investigation for SCCD?
Owen.
So radiological.
Yes, the answer is HRCT.
HRCT partial use.
Gold standard will be HRCT. Okay. Other name for this disease is third window syndrome. Okay. So this will be HRCT. Okay. Now what is the hearing loss which will be seen? It's very easy to answer over here. Can somebody try? What is the
conductive hearing loss initially?
Conductive hearing loss initially.
In the later stages, there can be sensory neural as well.
Yeah. So if you are answer, either you should answer this entirely, or else अगर आप एक ही चीज लिख रहे हैं तो it should be conductive. Okay. So that is the most common answer. Okay. Then it comes that which vestibular function test is diagnostic of this condition. We know this is VAM. So we'll be seeing this. We'll be seeing this VAM, both the cervical and the part when we discuss the recent advances and the investigations part. So this will be there. And then comes this thing. What is the full form of Fiesta MRI? Okay, so guys, what has been of late last 2-3 years, there has been a trend in every like all the 20 OSCEs, you will get around two questions asking the give the full form of this thing, and you'll be getting full 1 mark for it. So keep on revising your short forms. We'll be sharing on the group. आप भी जो book से पढ़ रहे हैं, keep making a PDF of it so that it becomes a I'll say a good revision point for you. So the full form of Fiesta is I'll try.
It's fast imaging employing steady state acquisition.
Great, Dr. Saab. Great, Dr. Saab. It's correct. Okay. So he has saved my energy. The answer is fast imaging employing steady state acquisition. Okay. So please go through it. Now here only I'll write one more thing, that MRI के जितने भी sequences हैं, whatever named sequences you remember, please write it at one place. वो कहीं ना कहीं आपको they will ask you, cis, flare, stir, they will be asked to you. Okay, so we'll keep on repeating all these things multiple number of times. But the problem with these type of I'll say short forms is if you don't revise it multiple number of times, so it's likely to be forgotten. Because the problem which plays over here is the time. The time when it runs in the backward direction, it is like very difficult that to remember it. Okay, now coming to enumerate any two surgical approaches for its management. So basically, Scott. Yes, Doctor Saab. All ये पूरा Scott से दिया हुआ है. So please write this thing. यहाँ पे there is a named technique which is being used. Just remember the name. They loan parne occlusion. Okay. So basically, जहाँ पे round window को they either they plug it round window. Okay, or they cap it, okay, or they resurface it. This is the terminology which is given in your Scott Brown. And after that, whatever you answered, that your mastoid approach, all those things, they can be a part of the answer. So again, I'll emphasize that thing only because these are the starting classes. by the I'll say middle of the course, you will be getting all these things into your mind. Please answer separately for each question. Write separately the question number for each question too. And third thing is, don't have this confusion कि मैं question number 1 में I'll write too much details and 3, 4, 5 मैं खाली छोड़ देगा, तो उससे कोई फायदा नहीं होगा. आप 1 में बहुत ज्यादा भी लिख देंगे तो भी you'll be marked out of 1 only. If you leave 3, 4 and 5, so those numbers are gone. So my request to you guys will be, please जब भी आप question attempt कर रहे हैं, make sure to attempt all the questions. It shouldn't be that कि आपने attempt नहीं किया. That is unforgivable. गलत लिख के fail हो जाना it's okay, but खाली छोड़ के आना is unpardonable thing. चलो, moving ahead. Again, same simple sample of the question. This has been asked 2-3 sessions back, and it is very common. Okay, very common. Otosclerosis and stapes surgery. Very important topic. Okay, so please, you cannot forget it. So yeah, the first one is this is second is birth. This first is perforator. Please check it. If you find something else answer, please do get back also. Okay, it's not that if I am saying something to sahi hoga. I have checked in multiple articles, so this is the best answer I could find. Second is your Larkin's hand birth. Third, I leave it to you. Can somebody take a try? Skeeter. Very good. Skeeter has been asked 3-4 number of times. Individual question of Skeeter has also been asked. Okay. So now remaining questions after this, they are asking mostly towards the surgical complications. So can you tell me, name the surgical procedure where they are used? It's easy now. Staped surgery. Okay. Someone is not able to join. Okay, so surgery we know. Now again, simple one. Mention the no contact tool for performing this procedure. Can somebody answer?
Laser.
CO2 laser.
अब आया CO2 लेजर का नाम. तो यहाँ से अपना एक we have another question. CO2 लेजर से 2 चीजें आती हैं. What is the wavelength of CO2 laser and who invented CO2 laser? Why is this important? Because this was invented by an Indian. Can somebody take a try? Not a part of this question. Yeah, 10,600. आगे unit क्या है? Nanometer. Okay, because this is also important. You cannot leave it blank. And what was the name of Dr. Sahab who invented it?
Kumar.
Yeah, great. Yeah, you got it. C. Kumar Patel. Chetan, if I'm not wrong, Chetan Kumar and Patel पूरा नाम था. I'll share his image also while we are discussing the scientist वाला जब group हम लोग पढ़ेंगे, तो his image will be there. So it is one of the important scientist image that you should remember. ठीक है. This will discuss in the laser section जब recent advances में lasers पढ़ेंगे. This will again come. So again I'll ask the same question. It will be very good if you will answer it. So it is a good thing. Okay. Now enumerate any 4 intraoperative complications of this procedure. So that is
Lymphatic.
Yeah. So all those things are there. Lymphatic gusher hai, CSF gusher hai. So all those things you should remember. And what in this I should like one point from my side is you can always go from one step to the other step. So you can easily start कि there is injury to the TM flap or the perforation can take place, or then you should go inside the injury to the ossicles, or then finally that CSF gusher will be there, injury to facial nerve. All these things can be there. Now apart from that, any other question? Okay. So instrument for stapes surgery, they are a must know. Okay, too. And instruments के अलावा we'll be seeing about there are multiple named pistons which are available. Okay, so there are multiple named pistons. This is one nitinol you should not forget. But there are multiple, but there are multiple other plethora of them. We'll share the whole PDF. This is just a sensitizing topic. This is something like that. You have to lay some more focus on this topic. This is not a regular topic. Okay. So moving ahead on the thing. Now from here, it's like I say easier things will be coming now. What are they asking over here? They are saying that there are parents of 3.5-year-old child who has become totally deaf following an episode of mumps infection. both parents are teachers by profession, and now you have to counsel them regarding your strategy. Okay, so Dr. Counseling station can be asked as an OSCE, or it can also be asked as your table viva oblique ward round में, कि वहाँ पे ward round में they might put a patient, कि this is a patient who has been planned for CI, and now you have to counsel the patient. For example, there is a patient who is having CA larynx. He is planned for total laryngectomy. Now counsel the patient. Okay. There might be a patient who will be put up for some thyroid disorder and planned for thyroid surgery. Now again counsel the patient. So getting my point. So these can be these type of setting stations can be placed. So my job over here is to tell you how to approach this question. सबको पता है कि अभी उसको तुम आप लोग how you will treatment is you have everybody knows कि हाँ इसमें ये treatment अभी can be given to the patient, but how to go about counseling. So I'll take 2 minutes and I'll finish this question. So first thing, please remember, whenever you talk to the patient or his relative, whosoever is there, please wish the patient or wish the relative namaste, good morning, whatever you want to wish, please wish. Second, introduce yourself. Dr. Saab, my name is Dr. Shubhankar Tiwari. Today is my exam. Okay, so today is my exam और मुझे थोड़ा सा इस बच्चे को देखना है या आपको देखना है, इसके लिए मुझे आपका अनुमति चाहिए. You have to ask the history. This is I'm telling in total, okay, not just pertaining to this case, in total. So you have to take the history, what happened. Then basically you have to explain the person the sequelae of the disease. Reassure the patient. Reassure is always one of the important thing. What all options do you have? Especially अगर आप surgical point of view से बात कर रहे हैं, you have to explain whether there is any non-surgical workup. Like suppose here example, if you are counseling them for cochlear implant, so you have to tell them about the workup, about the surgery, about the cost, about complication, about follow-up. Everything you have to say. And then after that, you have to take any doubts from the patient. Doubts from the patient. And after that, when you finish everything, just say you have started with a wish, you have to thank you the patient. Please follow it till the time you pass your exam. Okay? Because in DNB, these people are very particular about it. I have heard my seniors, I have not seen it presently. Initially, before 2016, what used to happen was कि OSCE में पास होना अलग से कंपलसरी होता था. Long case and short case you had to pass separately. And that time what they did was that if you ये आपका नहीं, you do not wish the patient, you did not say thank you to the patient, you did not take permission from the patient, they had even given negative marks to the candidates. Okay, so this is one of the area where just be little bit careful till you pass your exam. उसके बाद you are on your own. अच्छा, apart from that wishing wala thing, there are two more things where DNB plays with us. One is the expiry date. It has happened दो बार मैंने देखा है. One as when I was a resident and once after coming to this side of the table, that image of a drug was given, drug number X. यहाँ पे कुछ दिख रहा है, expiry date is visible, and the question is being asked, how will you give the drug to the patient? The answer will be, if the expiry date is shown, please एक बार हमेशा scan the drug, whatever is like flashed in front of your eyes. If it is expired, you have to write, sir, since this drug is expired, it should not be given to the patient. That should be your answer. One. Second will be your full form. Please do not use any short forms. Someone else wants to join? Just a minute. Just a minute. Okay, so after this expiry date and this full form, please do not use any short forms in front of you. I'll give example which happened in front of me. It would have happened because of, I'll say, panic only, that while giving the summary for your long case, the person who was presenting, he was like, diagnosis में finally में आप COM बोल रहे हैं. ठीक है. I know it's like you feel कि यार ये ऐसा कैसे हो सकता है, but it happened in front of my eyes and even after like provoking कि भाई COM का full form बोलो and so like sir no sir COM probably this should have been some mental block after like working from 8 o'clock till 4 in the evening without food, so your like brain also shuts down. But please take it that way. Whenever you are speaking chronic otitis media, atticoenteral type or squamous type, whatever you are answering, there's no space for short forms until you pass your exam. Okay. So after this thing, third thing, let me go. Now from here, the easy ones are there. These images are from your spot itself. Okay. This is a spotter. See, whenever this dip is at 4000 kilohertz, what will be the answer?
Noise induced lecture.
Noise induced. Yeah? This will be noise induced. If this dip is at 2000 hertz, then what will be your answer? It's easy, right? Karahat's notch hai, photosclerosis hoga, and yeah, and then there will be your Viva questions that why is this Karahat notch over there? What is? Then your whole things will go towards your otosclerosis wala thing. The second, one of the very hot topics of this session will be your ANSD. Okay, ANSD stands for Auditory Neuropathy Spectrum Disorder. Okay, so they are asking what are the characteristic features of ANSD. ANSD, Scott Brown ने एक छोटा सा section they have given it to you. Okay, so for ANSD, they have given a small section in Scott Brown. Please go through it. Else, I'll share you a small PDF. उसमें slide share की I think there are 5 to 7 slides are there, and there are PDF of I'll say only one page. So go through that. It will help you for that ANSD. If someone of you, I think 2 people are preparing for theory exam also. So for that also it will be helpful. ANSD is important topic. So ANSD के important thing which you have to know is that there is normal to raised PTA. In simple words, PTA is normal. ठीक है, there is normal OAE, there is normal cochlear microphonics. हाँ जी, very good डॉक्टर साहब. Para is abnormal and there is poor speech discrimination. Okay, yeah. So this is all about ANSD. Now what is this? This is histological types of hearing loss. Basically your presbyacusis is of this type: sensory, neural, vascular, mechanical, intermediate, mixed. इसमें कुछ और, there's nothing much to be read. You just should know about the histological types. They might ask you the various types for 1 or 2 marks. So it shouldn't be like कि you just stop after saying sensory and neural. उसके अलावा भी ये 3-4 है. ठीक है.
Sir, I want to add one thing in ANSD.
हाँ जी
There is
बताइए.
delayed or absent ABR.
या बिल्कुल.
ये थियोरी क्वेश्चन था हमारा इस साल.
Great. They have already bombarded you with the ANSD already, है ना? चलो, if you are lucky, you'll find it in Osces also. Okay, that's great. Okay. So if you people get something or the other, ना, please keep on adding, है ना? You can put whatever info you have on the group also. It's not that कि भाई मैं सब कुछ organize कर रहा हूँ तो सब मैं डालूंगा. Exam तो यार आप ही लोग का है ना? अच्छा चलो, let's move ahead without wasting time. So every time you will get 1 or 2 drugs in your exam. ठीक है. So pharmac section should be one of your because it is generally easier section, easy to score. So pharmac section पे थोड़ा सा अपना पकड़ बना के रखना है. So they are giving you an image of dexamethasone. You just scan through it. There is no expiry date visible over here. They are asking to you what is the indication for dexamethasone. Then they are asking technique for intratympanic injection, advantage and disadvantage. So can somebody quickly answer for one indication for dexamethasone? It's an easy one.
Idiopathic.
Sudden sensory neural hearing loss. Anything else from your side?
Medical management, many of these.
Yes, doctor. So tinnitus, Meniere's disease, and treatment they can be given. Okay. So technique of giving the intratympanic injection, what Scott Brown mentions is entero-inferior quadrant. This is what we were also taught, but there might be a possibility that आपके setup में कुछ change करके करा रहे हो. So, but for answering over here, write whatever is mentioned in the book itself. Okay. So giving the advantage and the disadvantage. Advantage you can write if the drug delivery is directly through the round window to the injury. Round window, and disadvantage and basically कि it bypasses the blood circulation. तो blood में नहीं जा रहा है. So basically the disadvantage of the steroids are taken care of. Okay. So here only they can ask you one more question कि steroids के side effects क्या होते हैं. Okay, so I'll just start answering from here only. The first one will be nausea and vomiting, gastritis. It's even said that if you will take these steroids on all empty stomach, this might lead you to gastric ulcer. So it is generally advised to take pantoprazole or omeprazole in the morning, have breakfast, and after that take these steroids. Okay. Then after that, what else can happen? In the eyes, there can be cataract, glaucoma. Then there will be osteoarthritis, AVN of hip and all. And there will be BP, sugar, all those things will be raised. Okay, there will be multiple other things. आपको pancreatitis वगैरह भी होता है. ठीक है, तो this is just to complete the list. Okay, so moving ahead of dexamethasone, there is one more steroid. हाँ जी बताइए.
Sir, can you please repeat what is the technique of giving DEXA injection, sir?
Technique of giving the DEXA injection. Okay, so technique of giving DEXA injection में what book mentions is that there are multiple ways to deliver drug to the middle ear. Okay, you can give it through syringe, you can give it through grome, you can give it through microwave or microcatheter.
Minute device.
हाँ, or minute device. Yes, and you can give it either endoscopically or through microscopically. ठीक है, what books mention is the anteroinferior quadrant. ठीक है, you just pierce it, and the dose which I could find is 10 to 24
ml.
Yeah, ठीक है, 0.5 to 1 ml तक आप इंजेक्ट कर सकते हैं. ठीक है, because the volume of middle ear is around 1.5 ml के आसपास रहता है, so not more than 1 ml. This data is like given very absurd. कहीं पे they have written something, कहीं पे they have written something, but generally what is being routinely followed is approximate 1 ml of drug in the anteroinferior quadrant is being given. Okay.
Sir, but isn't it posterior quadrant which we should give ideally, sir?
Sorry, I didn't get it. Please repeat.
Isn't it the posterior quadrant which we should give ideally?
No, that
Because
is avoided.
No. पोस्टो इंफीरियर में तो मतलब फिर नहीं यार, एंट्रो इंफीरियर ही है. ठीक है, हाँ, इट इज एंट्रो इंफीरियर. व्हाई आई टेल यू, बिकॉज सी ऊपर से तो आपका ऑसिकल्स आ रहा है ना, सो सुपीरियरली विल नॉट गो. हाँ जी बताइए.
Actually, even I feel that injection we are usually given posterior inferiorly, and where we keep grommet we keep anterior inferiorly. This is what I know, because if you are giving through posterior inferiorly, it directly go through round window.
Okay. See, I'll just see. This is what I remember is the answer. जो आंसर बुक में दिया हुआ है. I'm not saying कि this is only correct. ठीक है, I'm not saying this is only correct. कि जो आंसर which I remember, which is as per your main book, is anteroinferior quadrant only. ठीक है, still I'll check it. Whatever what the point you are giving, that technically that is absolutely correct. कि posteriorly में the one thing is कि the exposure is more. Secondly, that the drug delivery will be directly towards the round membrane. That is absolutely correct. So, but
Ossicular damage.
again, हाँ जी.
ऑसिक्यूलर डैमेज के वजह से हम लोग वहाँ पे नहीं देता एंटेरो
exactly. So there are multiple.
Yes, sir. Even in my actual topic was
Site and technique depends upon the institution protocol, but book says, but what you are saying is right. It is given in
So
NTO.
my take will be see, these all things are भाई ये सब सेमिनार वाली चीजें हैं, फर्स्ट ईयर को रगड़ने के लिए यूज किया जाता है कि ये क्यों नहीं है, वो क्यों नहीं है. Ultimately when you will be practicing clinically ना, तो you will remember कि all this is bullshit. ठीक है, जब आप क्लिनिकली प्रैक्टिस करेंगे. ठीक है, so our aim should be to pass the exam, because till my basic purpose is that only. ठीक है, so my advice will be whatever is there is in the book, please write that. ठीक है, and one of you uttered one word that is absolutely correct, that is institutional protocol. Whenever you get stuck somewhere, ठीक है, whenever you get stuck somewhere कि ये ऐसा क्यों नहीं कर रहे, ये ऐसा क्यों कर रहे हैं, and if you don't know anything, just say कि sir this is our institutional protocol. समझ गया. ठीक है, बट इट शुड नॉट बी एब्सोल्युटली रॉन्ग कि आप इंजेक्शन की बात कर रहे हो और आप बोल रहे हैं कि पोस्टर सुपीरियर क्वाड्रेंट में लगा रहे हो, तो दैट इज एब्सोल्युटली रॉन्ग. इट कैन नॉट बी देयर. ओके, सो लाइक सपोजिटली इफ यू लैंड अप ऑन दिस डिबेट, की एग्जामिनर स्टॉप्स यू ओवर हियर कि भाई टेल मी व्हाई इट विल बी नॉट पोस्टर इंफीरियर और एंट्रो इंफीरियर, यू कैन हैव दिस इन योर किटी कि सर दिस इज द थिंग व्हिच वी आर फॉलोइंग एज पर आवर प्रोटोकॉल. ओके, So one more steroid tablet in front of you. So this is prednisolone basically. Uses in ENT we'll see.
Bell's palsy.
Yeah. So one very common thing is your Bell's palsy. Then anything else apart from Bell's palsy?
Sudden
Neural hearing loss. Then in your
acute thyroiditis.
Acute thyroiditis. Okay. Okay. Side effect we just saw in the previous slide. It will be the same. Okay. There is one more drug which is associated with your regular things. Tablet propranolol. This I have seen coming in the exam myself itself. Okay. So what are the uses in ENT? Uses में आपको
Thyroidstone,
Infantile hemangioma.
then migraine, infantile hemangioma, migraines,
vascular migraine.
Thyrotox.
So these are the three things which I remember. जहाँ पे this thing will be used. Infantile hemangioma में I have included images of infantile hemangioma after this drug will only. They have written the use of propranolol in a very I'll say lucid way. Okay, so this use of propranolol and after that steroids is the main treatment of for infantile hemangioma also. Okay, which can be a very potential question for you guys. Okay, now dosage we remember this is 20 mg. The side effects में basically the side effects of beta blocker. हाँ जी. So it will reduce the cardiac output. It will reduce the BP. Okay, it will cause
and asthmatics to be not given this medication.
Bronchial constriction. It causes bronchial constriction. Okay. And where will be used in caution? So वहाँ पे basically in people who are having sugar, people who are already having some respiratory issues. So in those people you will use it with caution. And what will you check in investigation? So basically you will do all the cardiac profile, ECG, echo, X-ray. All these things will be done before we start. Okay. So here is the image. Just I am enlarging the image. Just have a look. This image is from your Scott Brown itself. And given aside is the radiological investigation for this. The question says a 5-year-old child comes with parotid swelling. Given is the MRI scan for the patient. Identify the condition, syndromes which are associated with it. What will be the medical management? Okay. So can somebody take a try? The answer will be parotid hemangioma. Okay, this is a type of. अगर बहुत छोटा बच्चा है तो infantile है. But since it is 5 years old, so you will not write the answer as infantile hemangioma. Okay. So can somebody tell me what are the syndromes which are associated with this type of hemangioma? Name of syndrome?
Faces.
Yes.
Otobronchorenal.
Yeah. Otobronchorenal will be also a part of it, but phases is the main thing which you have to remember. Okay, so please remember the full form of this phases. And coming to the medical management, we have already seen before it. So this is a important section. Okay. Apart from this, there will be. I'm just deviating a bit from the otology section because this hemangioma में आपका ये भी आएगा. This is the image of subglottic hemangioma. Since I was going through this, the first volume of this Scott Brown, I included all the images associated with it. This is the image of subglottic hemangioma. I'll just enlarge it a bit. Okay. And what have they been treated with? Propranolol. Okay. So this is So you should remember the drug propranolol हो गया, steroids हो गया, and इसके अलावा भी there are multiple additional newer treatments which are available for them. Please we'll study for them. Okay, so this is the classification over here. इसमें से आपको जो what you have to see is what is the full form of RICH and NICH. One, basically the ISSVA, that is the International Society for the Study of Vascular Anomalies. इन्होंने इसको दो भाग में बांट दिया. ठीक है, हेमांजियोमास को. There will be one will be the vascular tumors, other will be the malformations. Okay, and the other name which you have to remember from here is Kaposiform hemangioma. बस. इसके अलावा you don't have to ratify the whole table and all. Just remember this image. There is something of this kind related to the subglottic hemangioma. Here the subglottic space is reduced. Since the subglottic thing was coming into picture, I just purposefully put this classification system in front of you due to the subglottic region. Please remember these three named classifications. One will be your Cotton-Myers, second will be your McCaffrey, and third will be other distant cousin by the name of Bogdasarian classification of posterior stenosis. Okay, not related with this. I'll not discuss it over here. Just because the subglottic hemangioma and subglottic stenosis was coming into the picture, I purposefully brought these three names into your discussion. So these three names,
sir, just
please
a question, sir.
remember. हाँ जी बताइए.
Sir, what is the full form of RACH and NACH, sir?
It's rapidly involuting congenital hemangioma and non-involuting congenital hemangioma.
Congenital hemangioma.
Okay.
Thank you, doctor.
Okay.
ठीक है?
Okay.
Just mention it there only. Lovely. ठीक है? So moving ahead. Again, coming back to the otology question. So what they are saying is there is a child who came with fever, otalgia, post-auricular swelling since 1 week, and they are asking. They have given you this image. What is Gradinego syndrome? And they are asking enumerate named approaches to Petrus effects. If I am not wrong, ये भी इस साल पूछा था approaches to Petrus effects.
Yes, sir. This was a question along with the diagram they have asked.
Oh, okay, great. ठीक है. Chalo, that's good. Acha, from here only, just a point. This is one of the very important thing. This we will discuss times immemorial, especially when we'll go through the COM main case presentation. Complication of chronic otitis media. This is very important. Okay? Please read it from wherever you have read again and again, and if possible, just go through Shambog once again. I think 8 to 10 pages का उसमें दिया हुआ है. If you don't have it, just let me know. I'll find it out and send it to you. Just go through this. केवल complications of COM के ऊपर. बाकी I am not pushing you कि हर book पढ़ो. This is very beautifully given in Shambog, and there are multiple classical signs, classical names which have been given जो बार-बार exam में पूछते हैं. Okay. So can let us move ahead. What is Gradinego syndrome? Can somebody take a try?
Sixth nerve palsy, fifth nerve involvement.
Palsy,
Fifth nerve
along
involvement.
with
3D, diplopia,
deep seated retroorbital pain.
seated retroorbital pain, and third will be discharge. Okay. And how will be the discharge? The discharge will be relentless. Okay. चलो ठीक है. So you have seen petrositis. Please go through the classifications. Classification बोल रहा हूँ. Named approaches once again. You have to divide the approaches into two halves. The hearing sparing approaches and the hearing preserving approaches. है ना? Please remember the named approaches. I'll share the entire PDF with you guys. Okay. Apart from this, two more questions over here. जैसे complications of COM is important, ऐसे ही complication of CRS is very important. It's very important, and they will ask you Chandler's classification or the any CT scan of the periorbital involving the periorbital space, reaching the lamina, all those type of things. These are very important. And here only, please read again anatomy of cavernous sinus. And इसी के बगल में there is one structure by the name of Michel's cave. ठीक है? So please go through it at your own pace, because these are the topics which you can read it अभी, because your mind is at peace. Once the डंडा comes कि अभी 2 हफ्ते में एग्जाम हो रहा है, तो फिर then it becomes a hiffy jiffy. You have to just push जल्दी आगे चलो, वही चलता रहेगा. So this is the time which you whatever things I'm writing in the corner, please take out some time and at your own pace, please go through these things. These are like multiple things can be asked from them. Okay. So here, this is a table from Scott Brown from your otology section from pediatric box, that this is a type of Viva question in acute otitis media. What are the clinical recommendations when you will give the antibiotic? See, in clinical practice, invariably antibiotic देते ही रहता है, but if the examiner is asking when will you give the exact things it is asking, you have to answer these following
the stage of separations.
Yeah, बिल्कुल. Okay. So these are the various named signs over here. Like just we saw the Gradinego syndrome. A confusing thing with that is your Businger's sign. Then will be your delta sign. This is important. The CT is important because every time you go through the complications of COM, whenever you land up in lateral sinus thrombosis, the delta sign will come into picture. So this is important. And ahead over here, this is the Heiselberger sign. Just associated with it. That's why I had included it in the discussions. There is a small PDF which includes all the signs. This is around, I'll say, 10-15 signs honge. So I'll share it with you people. Just go through it and revise it from that only. Okay. So here is a table from this I just remembered. After we complete the sign test and all, we'll start around for 5 to 7 days. Daily we will discuss one syndrome. Okay, so for syndrome, how you have to remember about it? One is if there is any gene involved, that you should know. You should remember the typical species of the patient, because they will give you the image and they'll ask you identify the syndrome. Okay, then you should remember any special thing about the syndrome. Okay. So this we'll discuss in the following format. I think around 10 syndromes are there. They have given a table, comparison table, तो यहाँ पे already बना रखी है. Rachel Collins, Golden Heart, Charge, BOR. We just go through them. We'll discuss it one syndrome in one. जो around 9 o'clock we discuss the Osces. Really, I'll put one syndrome so that it like slowly settles down into your brain. Okay, I'll not push कि एक दिन में 4 syndrome पढ़ा सारे भूल गए. ठीक है? And apart from that, there is one more thing. Please remember which syndromes are autosomal recessive, which are autosomal dominant. So they'll ask what is the mode of inheritance of the following syndrome. Okay, so all the images are from your Scott bone itself. All are the potential Osces. Golden Heart the potential Osce है, and Rachel Collins too. It's always like golden MCQ. Now over here, two things. This is not a question basically. This is I'll say depictive CT scan. Images from Scott itself. Here they are showing cholesteatoma basically around the anterior attic. You should see over here. यहाँ पे what I'll request you guys is please read about Pruzak's case. ठीक है, this is very important and multiple number of times इसकी anatomy and इसका spread this will be asked to you. Apart from Pruzak's case, two more things: sinus tympani and facial lysis. These are the three things जहाँ से आपका discussion शुरू होगा. When you will start your COM Viva, as soon as he starts asking the spread of cholesteatoma, it will start from Pruzak's case. And if you flumber in the Pruzak's case anatomy or like related thing, so that will not be उतना मजेदार चीज फिर रह नहीं जाएगा. So these are the potential questions. Please go through it. Okay. ये हो गया. Please read about bastard obliteration and gynecoloplasty. I'll share the notes in the group itself. Okay, so if you have not read it from outside, please go through it. Okay. Now these things just from the same setup, so I thought to include it in today's class itself. What are the advantages of canal wall down? What are the advantages of canal wall up? Okay, I'll not bore you up by just reading around the same thing. Same चीज है, इसको पढ़ना है. It is important. ठीक है, I'll discuss it when we go about the surgical management of Viva. इसमें क्या-क्या Viva में questions पूछते हैं, then we'll touch upon this. अच्छा, अब यहाँ पे there are two very important questions hidden over here. I'll just highlight it. Guys, what is residual cholesteatoma? If they ask you, you have to mention the same thing. That residual cholesteatoma is basically the keratin epithelium that the surgeon has failed to remove while the initial operation. And what is recurrent cholesteatoma? Basically, this is when the squamous epithelium again begins to grow into the middle ear cleft. And this term recidivism is used combining both of them. So please be clear about both these terms. What is residual cholesteatoma? What is recurrent cholesteatoma? What is recidivism? We will again deal with it in particular when we go with the COM case presentation. So just in the same pages, so that I included it. Okay, now a few more Osces for you. These are the potential questions. Last 4 slides are left. Just give me 5 minutes. I'll finish it. Okay. So please see this image. Can you see something special about this? क्या दिख रहा है? Bifidula. Great. Bifidula. So the मतलब आपने जो ये है आपने पकड़ लिया. There is something called as Callan striate. ठीक है? So can somebody tell me there are 3 things in Callan striate?
One is a cleft palate, sir. Second one is a bifidula.
Okay.
Third one I don't know.
एक मैसेज आया. Just a minute. So here one more thing, please remember कि what is this syndrome where it is associated. Okay, so this is very commonly asked.
Pallister Hall.
Yeah, there are 2 syndromes. There will be one Pallister Hall, वो आगे आएगा. And यहाँ पे जो there is something called as Loeys-Dietz syndrome. This is associated with bifid uvula. ये भी अगले पेज में this is a question in bifid uvula. And ये आपका triad of submucous cleft palate is there. That is the bifid uvula, translucent zone in the soft palate, and there is a bony notch in the posterior edge of the hard palate. Okay, so please remember this thing. This is important. They might ask you that what are the three parts of triad and which syndrome is associated with bifid uvula. So answer will be lowest gate syndrome. This image is basically a tongue tie. The scientific name for this tongue tie is ankylosing. Okay, just the name is nothing else apart from it. So here is the syndrome which doctor was saying about. This yeah. What is the finding which is seen over here?
Epiglottis
Epiglottis is bifid. Yeah. Okay, so here the epiglottis is bifid. Now this thing is seen in the Pallister-Hall syndrome. Bifid epiglottis. Okay, so for today, please remember these two syndromes. पहला हो गया Pallister-Hall syndrome. Pallister-Hall में your epiglottis is per. Please catch the words P and P. तो एक में epiglottis is your which is bifurcated, and the second one will be your lowest gate syndrome where the uvula is bifurcated, and this generally seen in part of Callan triad. Okay, so please go through the Callan triad wala part. Okay, so this is again your rectification wala cheez hai. What is the definition of cerium? Please remember, this is given from your Scott Brown. What are the incidences? Isme just remember what is most common. So in the extracranial, the post-auricular abscess is most common, and in the intracranial, the brain abscess is most common. Brain abscess का अगला क्वेश्चन आपसे पूछते हैं stages of brain abscess. These are just the Viva question which I am just sensitizing you. Okay. Before we go with the cerium squamous case, I'll share with you a PDF of 20 pages which contains 100 questions of entire Viva of cerium squamous. So if you have not read anything about cerium squamous, तो वो पक्का पढ़ के जाना है. And if you are like कि हाँ I have read it multiple number of times, सब कुछ पढ़ा हुआ है, so it will again help you in retaining much of the matter and in effective revision. Okay, so with this I come to the last slide for today. I just marked a few slides back. The sinus tympani is very important. Okay, so this image is from Scott Brown, which tells you what are the types of sinus tympani. Type A, B, and C. So this again I'll tell you without teaching you. It's very important. Okay, please go through it. It should not happen कि you are taken aback कि वहाँ पे CTA में जा रहा पूछ रहा है what is the type of sinus tympani and you are like कि ऐसा क्या होता है भाई मैं तो सिर्फ sinus tympani सुना था. So this is a potential question, and without saying the boundaries of sinus tympani are very important. So you should be remembering that superior ponticulus, inferior subiculum, lateral में mastoid segment of fascial nerve, and medially में आपका posterior semicircular canal आएगा. So this is also very important. Whenever you remember it, इसी के साथ इसका importance आता है. The importance we all know that this is a hidden place because there are like the cholesteatoma, which is very commonly residual over at this place. So this is the importance, and over here only, this is my personal confusion. In the first year, I got so much scolding confusion between facial recess and sinus tympani. So please remember the boundaries of facial recess, sinus tympani separately. You should not forget it. Okay. So here only, just two more things are there. Please read about Mary's index, full form of Mary's index. जैसे ही आप Mary's index पढ़ोगे, the second question which will come is, do you know any other index apart from Mary's index? Can somebody take a try?
Spite.
I think with Jag.
Spite.
Oops index.
ठीक है, Oops index and Spite index. So both of them, just इसी paragraph के नीचे they have given this a short, small 4-5 lines paragraph is there in Scott Brown. ठीक है, so please go through it. We will discuss all these things when we'll go through this your long case. अभी just I'm not pushing it too further. It's just a sensitization class. That's why I've named it part 1. There are multiple other things which are left. So once I complete your Scott Brown एक बार at least, so then I'll start with the Lalwani wala part, and when we'll go into the head and neck, तो सुल्तान प्रधान के questions उसमें I'll include it. Okay, so here अच्छा एक और ये बचा है भाई, देख लेना please. What is Glasgow Belfast rule of thumb? They ask in OSCE also. Viva में it's a Viva point. ठीक है, and what is Glasgow benefit block? Both I have mentioned it over here. Just please rectify it. अच्छा sorry. Last question. ठीक है. What is the name of this classification?
Cogman classification.
Thank you, Dr. Aishi. The answer is Congdon classification. ठीक है? The name is Congdon classification, and I'll just write it. देखो A is preauricular, तो आंसर में A का मतलब भी preauricular हो जाएगा. ठीक है? Then B will be marginal helicine. C will be plural. D will be post helicine. Yeah, it's on the posterior part. This is posterior helicine. Then E will be post auricular, and F will be heliconodular, and G will be central. ठीक है? Finally, it comes to an end. So please remember the named classification. Okay, this is important. I believe like you are lucky. If you'll be lucky, you find this classification. So at this point, I rest my case. Any points, any updates, or anything from your side